So imagine placing a grieving woman inside a functional magnetic resonance imaging machine, an fMRI scanner.
Right, a brain scanner.
Exactly. And she has just lost her sister to breast cancer. The wound is totally fresh, the grief is heavy, and when you project a photograph of her deceased sister onto the screen inside that scanner, you expect to see, like, the brain's pain centers light up like a Christmas tree.
Which makes sense. I mean, she's in agony.
Yeah, and they do light up. The dorsal anterior cingulate cortex, the insula, these areas that process profound social and emotional agony, they just flood with metabolic activity.
Yeah.
But what you do not expect, what completely defies standard logic, is for the brain's primary addiction center to simultaneously flood with dopamine.
Which is exactly what researchers found in a landmark study published in the journal Neuroimage.
I really want to make sure you listening to this right now grasp the weight of this. A woman is experiencing like the most agonizing emotional pain imaginable, and her brain is reacting to the memory of her sister the exact same way a heroin addict's brain reacts to the sight of a needle.
Yeah, it forces us to completely reevaluate what craving actually is on a biological level.
It's wild. So what is the mission for us today with all this?
Well, the mission of this deep dive is to really understand the incredible complexity of treating substance use disorders. We are pulling from a massive stack of textbooks, clinical guidelines, and neurobiological research to figure out how clinicians assess what's going wrong, how they navigate cultural differences, and the psychological tools they use to rewire a hijacked brain.
Okay, let's unpack this, because in this fMRI study, researchers were looking at two very distinct categories of mourning, right?
Yeah, exactly. First, there is what they call non-complicated grief. This is the painful but ultimately adaptive process of mourning that most people go through.
The normal kind of grief.
Right. The intense pangs of sorrow eventually subside a bit, and the person integrates the loss into their ongoing reality. But then there's complicated grief.
And that's where things derail.
Completely derail. It becomes prolonged, unrelenting. The person is basically consumed by this intense daily yearning and a constant psychological searching for the deceased.
It's like a feeling of being permanently stuck in the immediate aftermath of the loss.
Exactly. So when they put the women experiencing non-complicated grief in the scanner and showed them photos of their lost loved ones, the fMRI showed a reduction in activity in the nucleus accumbens.
And just as a refresher for everyone, the nucleus accumbens is it's the brain's primary dopamine hub, right?
Yep, it's the reward center. It fires when we anticipate a great meal, when we gamble, or, when someone consumes an addictive substance.
So for the women with standard, non-complicated grief, that reward center was just quiet.
It was quiet. But for the women suffering from complicated grief, the nucleus accumbens lit up with this massive reward-related activity.
That is just so counterintuitive.
It gets crazier. The greater the activity in the nucleus accumbens, the higher those specific women scored on clinical assessments, measuring their self-reported yearning for the deceased.
Oh, wow.
Yeah. The brain's reward circuitry had literally been hijacked by the attachment to the lost person.
But let me challenge the underlying premise here, because my immediate reaction is that this sounds totally contradictory.
How so?
Well, why would a brain in the depths of agonizing grief trigger a reward response? I mean, if a woman is crying over a lost sister, she is consciously experiencing absolute misery. How is the brain simultaneously interpreting that as a reward?
What's fascinating here is how the brain categorizes survival mechanisms. Psychologists discuss two primary models of grief. The traditional one is the detachment model.
Which means what exactly?
It posits that the function of grief is to help us accept a harsh new reality, detach our emotional energy from the deceased, and, reinvest it in the living.
Okay, that sounds like standard psychology.
Right, and if that model's functioning, reminders of the person should slowly lose their biological salience. But the opposing framework is the reunion model.
The reunion model.
Yeah. The reunion model views grief as a biological protest against separation. You have to remember the mammalian brain is completely hardwired for attachment because, from an evolutionary standpoint, separation from the pack or the mother means death.
Oh, I see. So the brain is not trying to detach at all.
No, it is highly motivated to reunite.
So for the women with complicated grief, their brains are essentially just refusing to accept the permanence of the separation.
Exactly. The brain is treating the memories, the reveries, and that intense dwelling on the deceased as a reward, because those memories are the closest thing it can get to an actual reunion.
It's creating an addiction-like craving for the past.
Yes. The brain is dispensing a hit of reward neurotransmitters to reinforce the act of dwelling on the memory, even though the conscious emotional experience of that dwelling is one of profound sadness.
That is terrifying. The biological reality of craving is so powerful that it can override the conscious experience of pain. I mean, if a person's brain can become physiologically addicted to the memory of a lost relative to the point where they cannot function in their daily life, you begin to understand the sheer power of a chemical substance that artificially floods that exact same reward center.
It completely dismantles the outdated moral argument that addiction is just a lack of willpower.
Right, because you are asking someone to fight against the most fundamental survival and reward circuitry in their own head.
A chemical substance doesn't just create a bad habit. It artificially inserts itself into the neurobiological hierarchy of survival, placing itself above food, above water, and above human connection.
Okay, so if the brain is that thoroughly hijacked, how does a clinician sitting across from a new patient even begin to figure out the severity of the problem? I mean, we have to leave the pristine, objective environment of the fMRI scanner and walk into the incredibly messy reality of a counselor's office.
Right, because a counselor can't put every patient in an fMRI.
Exactly. They cannot. Which, I guess, requires the clinician to act as an investigator.
That's a good way to put it. The initial obstacle is differentiating between a basic screening and a comprehensive assessment.
A lot of people listening have probably filled out a screening. You know, you go to your general practitioner, they hand you a clipboard, and there's a quick questionnaire asking, like, how many alcoholic beverages you consume in a typical week.
Yeah, but a screening is a very blunt instrument. It is designed solely to identify potential risk. It just asks a binary question. Is there a possibility of a problem here?
But if that screening comes back positive,
Or if a patient is walking into a specialized addiction treatment center, that blunt instrument is no longer sufficient. The clinician must conduct a comprehensive assessment to firmly establish where the patient falls on a highly nuanced continuum.
so it's not just a binary addicted or not addicted label.
Not at all.
Hmm.
We are evaluating a spectrum that moves from use to misuse to excessive use, all the way to a severe substance use disorder.
To navigate that continuum, the sources detail the use of structured diagnostic tools. And one of the classic examples they bring up is the CAGE questionnaire.
Right, which was originally developed just for alcohol.
But the modern clinical standard has evolved to the CAGE-AID questionnaire. And the AID stands for Adapted to Include Drug Use.
Exactly. It breaks down into 4 deceptively simple questions based on the acronym CAGE.
Walk us through those.
Sure. The C stands for cut down. As in, have you ever felt you ought to cut down on your drinking or drug use?
Okay.
The A is for annoyed. Have people annoyed you by criticizing your drinking or drug use?
Ah, the social friction.
Right. Then the G is for guilty. Have you ever felt bad or guilty about your drinking or drug use? And finally, the E is for eye-opener. Have you ever had a drink or used drugs first thing in the morning to steady your nerves or get rid of a hangover?
I look at those 4 questions, and honestly, I have to admit, I'm skeptical.
Skeptical how?
Well, think about the complexity of a hijacked brain. All those profound neurobiological changes we just discussed with the fMRI, and we are trying to diagnose it by asking if someone feels guilty or needs a morning drink. It feels almost entirely reliant on a patient who is highly motivated to lie.
Yes.
If your brain's reward center is fiercely protecting its supply of a substance, you are going to minimize, rationalize, and deny absolutely everything.
Your skepticism is entirely warranted, and it touches on the fundamental flaw of self-reporting in addiction medicine.
So why use it?
The CAGE-8 is heavily utilized because it efficiently targets the psychological friction of addiction, the loss of control, and the social fallout. But the sources are explicit that a comprehensive assessment cannot, under any circumstances, rely on the patient's self-report alone.
Then be backup.
Obtaining collateral information is non-negotiable.
I think of a patient's self-report like a heavily edited movie trailer. It is meticulously cut to make the protagonist look as reasonable as possible, you know, to downplay the chaotic scenes and to completely hide the massive plot holes in their timeline.
That's a perfect analogy.
And the collateral information, the interviews with the spouse, the reports from the employer, the police records, that is the raw, uncut footage.
The counselor has to view that raw footage to understand the actual narrative. And the necessity of this collateral data becomes exponentially more apparent when treating highly intelligent, high-functioning populations.
Which the literature actually highlights.
Yes, the clinical literature frequently points out the extreme difficulty of assessing addicted medical professionals. specifically physicians.
Which presents a really fascinating paradox.
Mm.
A physician possesses immense medical knowledge. They know the diagnostic criteria for substance use disorders intimately.
They know exactly what the clinician is looking for.
Right, so because of their intellect and their deep understanding of pathology, addicted physicians frequently develop exceptional defense mechanisms.
Their rationalization and denial are incredibly sophisticated. When a physician is initially evaluated, they will almost universally and very convincingly deny the extent of their substance use.
How convincing are we talking?
Very. They can explain away tremors as just fatigue from a long shift, or pinpoint pupils as a normal reaction to a specific benign medication they claim to be taking.
So how does an assessing counselor even dismantle a defense mechanism built by someone who understands the human body just as well as they do?
You cannot rely on a standard interview. Evaluating a medical professional requires a multidisciplinary team with specific expertise in that exact population.
It's not a solo job.
No, and the gathering of collateral information becomes, frankly, aggressive. The clinician does not just interview the spouse. They mandate signed releases to obtain documentation from hospital administrators, they audit prescribing habits, they pull state pharmacy records, and they interview nursing staff who work alongside the physician.
Wow. They are essentially building a forensic case.
Because without that external, undeniable data, the physician's intellect will completely mask the severity of the disease.
But beyond the paper trail and the interviews, there is also a physical reality happening in the room, right? The body itself often betrays the denial.
The physical assessment is paramount. If a patient is sitting in the counselor's office and begins to manifest physical symptoms of withdrawal, the subjective interview must immediately pivot to objective medical measurement.
So they stop asking questions about feelings and start measuring vital signs.
Exactly. Clinicians utilize standardized scales for this. For alcohol withdrawal, they use the Clinical Institute Withdrawal Assessment, or the CIWA. For opioids, it is the Clinical Opiate Withdrawal Scale, which is known as the CIWS.
I was looking at the CIWS scale in the sources, and it measures things like resting heart rate, sweating, bone and joint aches, runny nose, and pupil dilation.
Right.
But let's dig into the why here. What is actually happening biologically that causes a person's pupils to dilate or their skin to pour sweat just because they haven't taken a pill or a shot of heroin?
To understand the physical manifestation of withdrawal, you have to look at an area of the brainstem called the locus coeruleus.
The locus coeruleus?
Yes.
Yeah.
It's the brain's primary source of noradrenaline. It basically controls our baseline level of wakefulness, breathing, blood pressure, and general alertness.
Kind of like the body's idle speed.
Exactly. Now, when a person takes an opioid like heroin or fentanyl, the opioid binds to receptors on the locus coeruleus and severely suppresses its activity. Noradrenaline production drops, blood pressure falls, respiration slows, the pupils constrict into those tiny pinpoints you see.
So the entire system is deeply depressed.
But the brain is highly adaptive. To counteract this massive suppression, the neurons in the locus coeruleus fundamentally change their internal machinery to ramp up activity. They're fighting against the weight of the opioid just to maintain normal baseline function.
Oh, I see. It's like pressing the accelerator of a car all the way to the floor while someone else is simultaneously standing on the brakes.
Precisely the right analogy. So what happens when the addict suddenly runs out of heroin?
The brake pedal is abruptly removed.
But the locus coeruleus is still pressing the accelerator to the floor.
Oh.
Yeah. The brain is instantly flooded with a massive, uncontrolled surge of noradrenaline. The physiological result is violent. The heart races, the digestive tract spasms causing severe cramping and diarrhea, the sweat glands overactivate, and the pupils dilate wildly because the sympathetic nervous system is just in a state of absolute panic.
So when a clinician is filling out a CIWS scale, they aren't just checking boxes. They are observing the locus coeruleus in a state of unregulated biological chaos. Now, hearing all of this intense forensic and biological investigation, a listener might naturally wonder, why go through the grueling process of gathering pharmacy records and conducting withdrawal assessments? Why not just hand the patient a cup, send them to the bathroom, and run a urine drug screen? It seems like the ultimate, undeniable, objective test.
It seems that way, but the clinical guidelines heavily emphasize the limitations and the potential dangers of over-relying on drug testing. A urine screen is not a magical truth teller.
Why not?
First, standard immunoassay drug screens have a false positive rate that hovers around 5%.
5%. That is a massive margin of error when a positive result could mean a person loses their medical license, goes back to prison on a parole violation, or loses custody of their children. What causes a false positive on a chemical level?
Well, standard urine tests rely on immunoassays, which use antibodies designed to seek out and latch onto specific drug metabolites.
Like little homing beacons.
Right. But antibodies are not perfectly precise. They look for specific molecular shapes. And many common, perfectly legal substances share a very similar molecular structure with illicit drugs.
Do you have an example?
Yeah. For example, the molecular structure of pseudoephedrine, a really common over-the-counter nasal decongestant, is remarkably similar to the structure of amphetamine.
So a patient takes a cold pill, and the antibody in the drug test gets confused, latches onto the decongestant, and flags the patient for meth.
Yes,
Yeah.
it happens. Furthermore, standard panels often completely miss certain synthetic or semi-synthetic opioids. But honestly, the most critical limitation of a drug screen is philosophical.
Philosophical.
A lab result is a snapshot of a single, isolated moment in time. It proves that a specific chemical was ingested. It does not tell the clinician anything about the history of the use, the patient's loss of control, or the devastating impact the substance is having on their family and career.
Ah, I get it. A positive urine screen indicates use. It does not diagnose a substance use disorder.
Exactly. The assessment has to synthesize the brain, the behavior, the collateral fallout, and the physical dependency altogether.
Okay, so once the clinician has completed that exhaustive synthesis, they have a clear understanding of the severity of the illness. The immediate next question is logistical. Where does this person belong?
Right. Placement.
You have a diagnosis, now you need a physical location for treatment. Because you wouldn't place a teenager experimenting with alcohol into a locked psychiatric facility, and you wouldn't send a patient experiencing severe seizure-inducing alcohol withdrawal home with a self-help book.
This requires navigating what are called patient placement criteria. And the absolute foundation of this process, which is dictated by both medical ethics and strict legal frameworks, is the principle of the least restrictive environment.
The least restrictive environment. The sources mention this is enshrined in laws like the Mental Health Act. It's not just a medical guideline, it is a civil rights mandate.
It is. The legal framework dictates that any treatment setting must satisfy two conflicting requirements simultaneously. First, it must provide a level of care adequate to meet the patient's clinical needs and ensure safety.
Okay, that makes sense.
Second, it must achieve that safety while imposing the absolute minimum possible restriction on the individual's civil liberties and freedom of movement.
Meaning inpatient hospitalization, where a person is locked on a ward and essentially stripped of their autonomy, is the ultimate last resort. The burden of proof is heavily on the medical establishment to justify taking away someone's freedom.
Exactly. If a patient is exhibiting severe psychosis induced by methamphetamine, or they lack the cognitive capacity to make basic survival decisions, or they are actively suicidal, involuntary admission may be the only ethical path.
But getting to that path is hard, right?
The legal threshold to achieve that is intentionally daunting. In most jurisdictions, an involuntary hold requires independent, rigorous examination by multiple mental health professionals, often two separate psychiatrists.
And they have to agree.
They must certify not only that a severe mental illness is present and causing imminent danger, but that no less restrictive community-based option could possibly keep the patient alive.
And even if that high bar is cleared, the state cannot just lock someone away indefinitely. The sources highlight strict temporal limitations.
Right. An involuntary admission might be certified for a maximum of, say, 30 days. At the conclusion of that period, or even prior to it if the patient contests the hold, a legal or medical board must review the case.
They have to reprove the case.
The institution must continuously prove that the severe restriction of liberty is still medically necessary. The absolute moment the patient stabilizes enough to be treated in a less restrictive setting, the law demands they be transferred out.
I want to explore the gray area here because this has to be the most agonizing part of a clinician's job. You have patients sitting in front of you, they're highly impulsive, they have a history of opioid overdoses, they are deeply depressed.
This raises an important question, yes.
Right, because they do not currently meet the strict legal criteria of being an imminent, undeniable danger to themselves. They refuse inpatient rehab. They just want to go home. As a clinician, you know that sending them home is incredibly dangerous, but the law says you must respect their autonomy. How do you bridge the gap between their civil rights and their very real risk of dying?
It is an immense burden for the clinician. When a patient represents a medium to high risk, but does not cross the threshold for involuntary commitment, the clinician is forced to architect a highly robust safety net within the community.
But how do you build a safety net for someone who is literally free to walk out the door and buy drugs?
You implement rigorous, multi-layered contingency plans.
Yeah.
The clinician cannot simply say, okay, I'll see you next week. That's negligent. They might arrange for daily telehealth check-ins. If the patient has a supportive and capable family structure, the clinician involves them intimately.
Like training them on what to look for?
Yes, training them on what warning signs require an immediate emergency room visit. They ensure the patient leaves the office with a prescription for naloxone, the opioid overdose reversal medication, and that the family knows how to administer it. They establish 24-hour access to emergency clinical care.
So the objective is to aggressively manage and monitor the risk while honoring the patient's legal right to remain in their own home.
Correct. But the moment that risk profile escalates, the moment the patient expresses a specific plan for self-harm, the calculus shifts, and the clinician must move toward a more restrictive environment immediately.
We've covered the biological assessment and the physical placement, but the literature makes a profound pivot here. It argues that placing a patient in the correct physical facility is entirely useless if the counselor is operating in the wrong mental facility regarding the patient's identity.
We must look through the lens of cultural humility. Addiction does not occur in a vacuum. It is deeply intertwined with a person's cultural background, their societal status, their historical trauma, and their intersecting identities.
Let's talk about the evolution of terminology in the psychiatric field here, because words matter immensely. For a long time, the gold standard was cultural competence.
Yes, the idea of competence.
And the underlying assumption was that culture was a subject to be mastered. A clinician could attend a weekend seminar, memorize a checklist of generalized traits about a specific demographic like this culture values collective family decisions over individual autonomy, and suddenly, boom, the clinician is deemed competent.
The concept of cultural competence has been largely discarded because it fosters arrogance. It implies a finish line. It suggests that a clinician can study a marginalized group and somehow achieve mastery over their lived experience. The field has evolved to embrace cultural humility instead.
Cultural humility, it's a fundamental shift in posture, isn't it?
It is. Cultural humility is defined not as a destination, but as a lifelong dynamic stance. It requires the clinician to maintain an interpersonal orientation that is deeply other-oriented.
Other-oriented.
Yes. The clinician must continuously and rigorously assess their own internal biases, acknowledge the inherent power dynamic between doctor and patient, and maintain a posture of knowing and not knowing.
Knowing and not knowing, I think about it like being an invited guest in a foreign country. You don't walk into someone else's home and immediately start critiquing their layout based on how your house looks back in your home country.
Exactly. You observe.
You respectfully ask why certain traditions are upheld. You accept that their way of moving through the world is entirely valid, even if it contradicts your own baseline assumptions.
That is the essence of the knowing and not knowing stance. A clinician may know the intricate neurobiology of the locus coeruleus, like we discussed, but they must humbly accept that they do not know what it is like to navigate the world in the specific body and with the specific history of the patient sitting right across from them. A massive component of this is recognizing intersectionality.
The idea that human identity cannot be reduced to a single demographic checkbox.
Right. A person's lived reality is a complex, overlapping matrix of race, gender identity, sexual orientation, socioeconomic class, and religious background. A heterosexual African-American male corporate executive experiences a vastly different set of societal pressures and systemic interactions than a non-heterosexual African-American female who is navigating poverty.
So treating them as a monolith based on race alone is essentially clinical malpractice.
It is, and the sources point out something even more fundamental. Culture doesn't just dictate how a person experiences addiction. It actually dictates how society defines the disease in the first place.
This blew my mind. The threshold for what constitutes problematic use is entirely subjective and wildly variable across the globe.
The World Health Organization has published extensive data demonstrating that the definition of a substance problem is deeply culturally dependent. Consider cultures where the consumption of alcohol is deeply woven into the daily social and culinary fabric.
Like in Europe.
Right. In Athens, Greece, or Santander, Spain, regular daily drinking, having wine with lunch and dinner every day, is highly normalized.
It's not just accepted, it's expected.
Therefore, the threshold for a clinician in those cultures to intervene and say your drinking is pathological is set significantly higher.
But if you shift contexts,
Conversely, if you look at a highly religious community with strong temperance traditions, perhaps certain regions in Utah or in
yeah.
Islamic nations where alcohol is strictly forbidden, that exact same consumption pattern of 2 glasses of wine a day would be flagged as a severe, deviant behavioral problem requiring immediate intervention.
What is considered a relaxed Tuesday dinner in one part of the world is classified as a psychiatric warning sign in another.
Exactly.
But we have to look at the darker side of this too. It's not just about social norms, it's about the legal frameworks that govern substances. A culturally humble clinician has to understand the historical context of drug laws because those laws often had very little to do with public health and pharmacology and everything to do with societal prejudice.
Now, we're just reporting what the sources outline here. We aren't taking a political stance. But the historical record highlighted in the text is glaringly clear on this. When you examine the genesis of drug criminalization, particularly in North America, the legislative action frequently mirrored periods of intense societal anxiety regarding specific minority or immigrant populations.
If a clinician is going to treat a patient, they have to understand the historical weight the patient carries into the room.
Exactly. The texts point out that the first wave of anti-opium ordinances in the late 19th century in the American West were not drafted because of a sudden medical revelation about opiate addiction. They were explicitly enacted to target, harass, and control Chinese immigrant railroad workers.
And the sources mention cocaine and marijuana, too.
Yes. Similarly, the early aggressive criminalization of cocaine was heavily spurred by racially motivated fears targeting African Americans in the South. And in the 1930s, the initial fervent push to federally criminalize marijuana was heavily driven by bias and fear-mongering regarding Mexican migrant workers in the Southwest.
So, when a counselor is sitting in a room with a patient from a marginalized community, they are not just treating a hijacked dopamine system, they are treating a person who is navigating a legal and societal framework that was historically weaponized against their demographic.
Right.
How does a clinician address that massive elephant in the room without turning a therapy session into a sociology lecture?
They utilize a specific clinical skill known as broaching.
Broaching, meaning the therapist initiates the conversation about the cultural differences rather than waiting for the patient to awkwardly bring it up, or worse, just ignoring it entirely.
Yes. If a white middle-class heterosexual therapist is treating a young biracial queer client, ignoring the difference in their lived experiences is a failure of cultural humility. The therapist must proactively broach the subject to ensure they are not making dangerous, silent assumptions.
The clinical literature provides a brilliant case study illustrating the power of this technique, focusing on a client named Charles.
Let's dissect Charles's case because it highlights exactly what is at stake. Charles is a biracial man who was transracially adopted by white parents as an infant. He enters treatment for severe substance use.
Now, a clinician operating under the old model of cultural competence might look at Charles's chart and think, okay, he is adopted, but he has a stable family structure. We will just proceed with a standard cognitive behavioral therapy protocol.
They make an assumption based on surface-level data.
But a culturally humble provider maintains that other-oriented stance. They realize they don't know what Charles's specific experience of being transracially adopted feels like, so they broach it.
The provider actively asked Charles how his specific intersection of identities, being a biracial man raised in a white family without access to his biological origins, was impacting his current mental state.
And by opening that specific door, the provider uncovered a massive hidden driver of Charles's addiction.
Charles revealed that because his birth records were sealed, he had absolutely no knowledge of his biological family's medical or psychiatric history.
He didn't know if his biological parents were alcoholics or drug addicts.
And that lack of knowledge had manifested as an all-consuming, paralyzing anxiety. Charles was terrified that he was walking around with a genetic time bomb for addiction.
That is a staggering psychological burden to carry. He was self-medicating with drugs to quiet the anxiety he felt about potentially becoming a drug addict. It's this tragic, self-fulfilling loop.
If the therapist had not practiced cultural humility, if they had not proactively broached the unique reality of his adoption, they would have spent months treating his behavioral symptoms while completely missing the core psychological engine driving the disease.
But once the therapist uncovered this, the treatment plan shifted entirely,
The therapist actually helped Charles navigate the complex legal system to unseal his records and obtain his birth family's medical history.
which directly alleviated the agonizing uncertainty, dramatically reducing his baseline anxiety and fundamentally improving his chances of maintaining sobriety. Cultural humility isn't just about making the patient feel seen, it is a critical diagnostic tool.
Yep.
So we have run the assessments, we found the least restrictive environment, and we've built a culturally humble therapeutic alliance. The clinician understands the patient deeply, but here is the massive roadblock that every family member of an addict knows intimately. What if, after all of that, the patient simply crosses their arms, leans back in the chair, and says, I don't have a problem, I'm not changing?
We now enter the domain of motivational enhancement, because you cannot rewire a hijacked brain if the patient is fundamentally opposed to the process.
Right.
To understand how a clinician generates motivation, we first must understand the architecture of change itself. We rely on the trans-theoretical model, frequently referred to as the stages of change.
The core premise here is that changing a deeply ingrained human behavior is not an event. It's not a light switch that gets flipped. It is a slow, cyclical process.
The model outlines 5 primary stages. The first, and often the most frustrating for families, is pre-contemplation.
Pre-contemplation. This is absolute denial.
The patient does not perceive that they have a problem at all. The negative consequences of their substance use are entirely projected outward onto others. They believe they are in control, and they have zero intention of altering their behavior in the foreseeable future.
It's the classic, my drinking is fine, my boss just has it out for me, and my wife is overreacting.
Precisely. The second stage is contemplation. This is a state of profound ambivalence. The patient is beginning to recognize that their substance use is causing friction, but they are simultaneously deeply attached to the substance.
So they are torn.
They are weighing the pros and cons, often remaining stuck in this stage for years, thinking about change, but totally paralyzed by the effort it requires.
Stage 3 is preparation. The ambivalence is resolving. The patient has made the internal decision to change and is gathering resources. They are researching rehab facilities or looking up local support group meetings.
Stage 4 is action. The patient is overtly modifying their behavior. They are actively abstaining from the substance, attending therapy, and rearranging their environment.
And stage 5 is maintenance. The active threat has subsided, and the patient is working to sustain the new, sober behavior over a prolonged period. But the clinical models always include a critical shadow stage, right? Relapse.
Relapse is deeply misunderstood. It is not viewed clinically as a failure of the model or a reset back to absolute zero.
How is it viewed?
It is recognized as a highly common expected component of the cyclical nature of change. A patient may cycle through the stages of contemplation, action, and relapse several times, gathering new insights with each cycle before achieving long-term maintenance.
Let's focus on that brutal first stage, though, pre-contemplation. You have a patient whose life is demonstrably falling apart. They're losing their job, their health is failing, but they refuse to acknowledge the drugs are the problem. For decades, pop culture and reality television have sold us a very specific solution to this: the intervention. You ambush the addict. You gather the family in a living room. You aggressively confront the person with a laundry list of their failures. You yell, you cry, and you deliver a harsh ultimatum. You force them to hit rock bottom so they have no choice but to change.
It makes for incredibly dramatic television. But clinical research has consistently demonstrated that the aggressive, confrontational rock-bottom approach is not just ineffective, it is often profoundly counterproductive.
Wait, I need to push back on this. Because if someone is blindly walking toward the edge of a cliff, doesn't a counselor or a family member have a moral obligation to tackle them? To aggressively confront their delusion and just tell them to stop?
The intention is good, but the mechanism fails because it ignores basic human psychology. We have to look at psychological reactance theory.
Reactance theory.
When you aggressively attack a person's behavior, their freedom of choice, or their core coping mechanism, their natural, hardwired psychological response is to defend it.
If I push you, your instinct is to push back.
Aggressive confrontation creates a massive wall of defensiveness. The patient stops listening to the logic of the argument and instead focuses entirely on repelling the attack. You end up pushing the patient deeper into their denial, reinforcing their alliance with the substance, and alienating them from the very people trying to help.
So the intervention actually makes the addiction stronger.
Often, yes. Recognizing this immense failure, led to a monumental paradigm shift in addiction counseling, moving away from confrontation and toward motivational interviewing, or MI, and motivational enhancement therapy, MET-T.
If motivational interviewing isn't confrontation, what is it? I mean, how do you convince someone to change without actually telling them they need to change?
MI is a collaborative, person-centered, and radically non-judgmental counseling style. The fundamental shift is that the counselor abandons the role of the authoritarian expert dictating terms. The goal is not to force change upon the patient, but to act as a facilitator, helping the patient safely explore and resolve their own internal ambivalence.
Instead of telling the patient why they should quit, you want the patient to argue themselves into quitting.
Yes. The core technique is called evocation. The counselor uses highly calibrated, open-ended questions designed to draw the motivation out of the client.
Give me an example of how that conversation actually flows in a room.
Instead of a counselor saying, your cocaine use is destroying your marriage, you need to go to rehab, which triggers immediate defensiveness, the counselor might ask, you've mentioned that being a reliable, present father is your most deeply held value. How does spending your weekends using cocaine align with that goal?
Wow, you are just holding up a mirror to the dissonance.
Exactly. You allow the client to sit in the uncomfortable gap between their stated core values and their current behavior. You don't judge the gap, you just highlight it. The patient begins to articulate the arguments for change themselves. When the motivation comes from within the patient, it is exponentially more durable than when it is imposed from the outside.
And what I find incredibly fascinating in the sources is that this powerful psychological tool isn't restricted to licensed therapists. We are seeing a movement to train families in these techniques through unilateral treatment programs.
This is one of the most vital developments in modern addiction treatment. Family members are historically the ones who suffer the most secondary trauma, and they feel utterly helpless when their loved one is stuck in pre-contemplation and refuses professional help.
So they just wait for the person to die or hit rock bottom?
Not anymore. Unilateral programs empower the family by teaching them the core tenets of motivational interviewing to use in their daily interactions.
So instead of a mother yelling at her teenage son every time she smells marijuana in the house, which just results in slammed doors and more sneaking around, she is trained to alter her communication style.
Yes, families are taught empathetic listening, how to avoid escalating arguments, how to roll with resistance rather than fighting it, and how to use positive affirmations to reward small steps toward change.
Does training a parent to be a pseudotherapist actually work, though?
The data is highly compelling. The sources detail a specific study involving the parents of young adults suffering from psychotic disorders complicated by heavy cannabis use. These are incredibly difficult, high-risk cases.
And what happened?
When the parents were trained in MI skills and applied them at home, the study demonstrated a significant, measurable reduction in the children's cannabis use. The parents became the active agents of change simply by altering the emotional architecture of their conversations.
It fundamentally changes the dynamic. You stop being the warden and start being a facilitator. Okay, let's assume the motivational interviewing is successful. The patient has moved out of pre-contemplation, they are motivated, they want to get clean. The counselor now faces the mechanical problem.
Rewiring the software.
Yes. How do you actually rewrite the software of a brain that has been heavily programmed by addiction? Here's where it gets really interesting, because we move into intervention strategies. And the undisputed heavyweight champion of behavioral change is cognitive behavioral therapy, or CBT.
CBT is ubiquitous in modern psychology, but its application in addiction requires a deep dive into classical Pavlovian conditioning.
Most of us know the basic Pavlov story. You ring a bell, you give a dog a piece of meat, the dog salivates. You repeat this enough times, and eventually, just the sound of the bell causes the dog to salivate, even if there is no meat. The brain has linked the auditory cue to the physiological reward.
In the context of a severe substance use disorder, the drug is the meat.
And what's the bell?
The bell can be an infinite number of environmental or internal cues. It could be the visual cue of driving past a specific bar, the social cue of seeing a particular group of friends, the tactile cue of holding a glass pipe, or an internal emotional cue like severe stress or profound boredom.
Through years of repeated use, the brain wires those cues directly to the nucleus accumbens.
Yes. When the patient encounters the cue, before they even make a conscious choice, their brain releases a surge of anticipatory dopamine. This creates an intense visceral craving. The bell rings, and the brain violently demands the drug.
How does CBT actually unring the bell?
CBT cannot erase the neurological memory, but it can build new pathways to override it. The cornerstone of CBT in addiction is a process called functional analysis.
Functional analysis.
The therapist and the patient act as behavioral detectives. They dissect the patient's addiction meticulously. They analyze the antecedents, the specific cues and triggers that reliably occur immediately before the drug use. And they analyze the consequences, the emotional and physical fallout that occurs after.
It's like a sports team breaking down game tape after a massive loss. You are watching the replay frame by frame. Okay, let's look at Tuesday. You had 3 months sober, but you relapsed. What happened at 2:00 p.m.? Oh, you had a confrontation with your manager. You felt humiliated. You left work early. You took your old route home past the liquor store.
The goal is to make the automatic unconscious loop conscious. Once the specific triggers are identified, CBT shifts to skills training. The therapist arms the patient with a toolkit of cognitive and behavioral strategies to interrupt the sequence.
Give me an example of the specific tools.
Behaviorally, it might involve extreme environmental modification. If driving past the old dealer's street is a massive trigger, the behavioral skill is mapping out a new route home, even if it adds 20 minutes to the commute.
And cognitively.
Cognitively, it involves training the patient to identify and dismantle distorted thinking. Addicts often suffer from euphoric recall, where the brain only remembers the initial high and completely suppresses the memory of the devastating crash. CBT teaches the patient to actively play the tape all the way through when a craving hits, forcing the conscious brain to remember the vomiting, the shame, and the financial ruin, not just the momentary relief.
It's about inserting a wedge of conscious thought between the trigger and the automated response. But there is a reality here that the sources acknowledge. Sometimes, especially in early recovery when the brain is screaming for dopamine, cognitive skills just aren't strong enough. A person can know all the CBT tools in the world and still succumb to the biological weight of craving.
Which is precisely why clinicians developed contingency management, or CM. If the brain is desperate for a reward, CM provides an alternative, immediate, tangible reward for abstinent behavior.
Contingency management is highly controversial. Every time it gets brought up in public policy, there is severe backlash. The core concept is giving patients positive reinforcement, often in the form of vouchers, prizes, or direct cash payments for providing drug-negative urine screens or attending therapy sessions.
The public pushback is completely understandable, but clinically, the mechanism is profound.
I have to play devil's advocate here. Are we not just bribing people to not do drugs? And on a deeper philosophical level, if an addict's primary problem is that their brain is hijacked by external rewards, isn't paying them cash just swapping a chemical addiction for a behavioral addiction to money and prizes?
It is a totally valid philosophical critique, but we have to look at the immediate life-or-death reality of the disease. A brain severely addicted to fentanyl is incapable of valuing long-term abstract rewards like health or family stability. The prefrontal cortex is compromised. Contingency management leverages the brain's hijacked reward system and temporarily redirects it toward survival. You are providing an immediate, concrete spike of dopamine that actively competes with the drug.
Does it actually work to get people in the door?
The empirical data is overwhelming. The sources detail a specific, striking study involving intravenous drug users. Researchers set up a needle exchange program. They offered individuals with severe opioid use disorder a small incentive between $10 and $20, plus a bus pass, simply for attending brief motivational enhancement sessions.
Okay.
Crucially, they also provided a $50 direct payment to the treatment clinic to cover the patient's intake costs.
So they removed the financial barrier and offered a small cash bribe. What was the yield?
The incentivized group saw a 52% treatment enrollment rate, compared to only 34% in the non-incentivized control group.
That is a massive jump.
When you are dealing with a population facing an astronomical mortality rate from overdose, an 18% increase in treatment engagement saves countless lives.
There is a very specific implementation of CM mentioned in the texts called the fishbowl approach. It sounds almost like a carnival game.
It operates on the psychological principle of a variable ratio schedule of reinforcement. When a patient provides a clean urine screen, they don't get a guaranteed $10. Instead, they get to reach into a literal fishbowl and draw a slip of paper.
A lottery system for sobriety?
Exactly. Half the slips might just say good job, offering no tangible reward. A significant portion are worth small prizes, like a $1 voucher or bus tokens. But a very small percentage of the slips are worth large prizes, a $50 gift card, or even a television.
Let's talk about the neuroscience of why a fishbowl works better than a guaranteed payment, because this taps into the exact same circuitry as a slot machine.
It utilizes dopamine prediction error. If I give you $10 every single time you pass a test, your brain quickly adapts, the reward becomes expected, and the dopamine release blunts.
It gets boring.
Right. But if the reward is uncertain, if you might get nothing, or you might hit the jackpot, the brain's reward center remains in a state of high anticipation. The variable schedule releases significantly more dopamine, creating a powerful behavioral drive to keep drawing from the bowl.
You are literally using the neurological mechanics of gambling to override the neurological mechanics of heroin. But that brings us back to my initial critique. What happens when the game ends? When the grant money runs out and the clinic takes the fishbowl away, does the behavior just revert?
That is the Achilles heel of contingency management. Research indicates that while CM is highly effective at producing immediate behavioral change while the contingencies are active, the durability of that change often weakens once the rewards are removed. Without the external incentive, the internal drive can falter.
So it is a powerful jumpstart, but it is not a permanent engine.
Which is why the clinical gold standard is the integration of contingency management with cognitive behavioral therapy. The clinician uses the powerful immediate rewards of CM to get the chaotic patient into the clinic, stabilize their behavior, and maintain early abstinence.
And then?
While the patient's brain is clearing, the therapist aggressively trains them in CBT skills. The CM buys the time necessary for the CBT to build the cognitive architecture. When the rewards eventually fade, the patient has internalized the tools needed to survive without them.
It is a brilliant, layered strategy, but the sources also highlight a completely different category of biological intervention, one that requires no therapy, no fish bowls, and no cash: exercise.
The clinical emergence of exercise as a targeted intervention for severe substance use disorders is fascinating. We are not talking about general wellness. We are talking about targeted neurobiological repair.
How does hitting a treadmill actively treat an addiction to hard drugs?
Let's look specifically at methamphetamine addiction. Chronic methamphetamine use is uniquely neurotoxic. It severely damages the dopamine receptors in the brain's reward pathway. When a meth addict enters recovery, their brain is physically incapable of producing or processing normal levels of dopamine.
This leads to profound anhedonia, the absolute inability to feel pleasure, joy, or even basic motivation. The world turns completely gray.
And that anhedonia is a primary driver of relapse because the patient knows that the only way to feel alive again is to use the drug.
So where does exercise come in?
The sources detail a highly specific 8-week clinical trial involving individuals in early recovery from methamphetamine. The participants were randomly assigned to a supervised progressive endurance and resistance training program, exercising 3 times a week.
Lifting weights and doing cardio, what do they find neurologically?
The researchers utilized brain imaging and found that the group participating in the exercise protocol actually demonstrated improved dopamine receptor binding compared to the control group.
Wait, the physical act of exercising was repairing the structural damage caused by the methamphetamine?
Yes. Intense exercise triggers the release of endogenous opioids, the body's natural painkillers and mood elevators. This internal opioid release potentiates dopamine efflux, essentially coaxing the damaged reward center back to life.
That is amazing.
The exercise was physically healing the brain, which in turn significantly lowered the patient's anxiety, mitigated their depression, and drastically reduced their rates of relapse.
We have spent a vast amount of time dissecting how to modify behavior. We've talked about CBT, the fishbowl, and exercise. But a listener might realize that everything we've discussed so far addresses the mechanics of the addiction. We are treating the behavior. But what about the deep, often agonizing emotional void that the substance was originally hired to fill?
To address the origin of the void, we must turn to the psychodynamic approach to addiction.
Psychodynamics. This branch of psychology traces its lineage back to Freud and psychoanalysis. For a long time, the psychoanalytic view of addiction was fairly dismissive, wasn't it?
Early psychoanalytic models were highly flawed regarding addiction. They largely viewed drug use as a regressive pursuit of pure pleasure, a failure to mature past infantile drives. But modern psychodynamic theorists, brilliant minds like Heinz Kohut and Edward Kansian, completely revolutionized the framework.
How so?
They discarded the idea that addiction is about pleasure. They define addiction as a profound disorder of self-regulation.
Self-regulation, the internal capacity to manage your own self-esteem, to soothe your own anxieties, and to navigate interpersonal relationships without falling apart.
Exactly. Modern psychodynamics argues that individuals vulnerable to severe addiction suffer from massive structural deficits in their psychological makeup. These deficits almost always stem from early childhood trauma, systemic abuse, or profound, repeated empathic failures by their primary caregivers.
Empathic failures, meaning a child is in distress and the parent is consistently emotionally unavailable, dismissive, or even abusive. The child never internalizes the feeling of being safe or understood.
Because the child never learns how to be soothed by another person. They never learn how to soothe themselves. They grow into adults who feel fundamentally empty, fragmented, or overwhelmed by chaotic emotions. Because they lack the internal psychological architecture to manage this pain, they turn to external substances. They use drugs as a prosthetic.
A prosthetic. I want to linger on that metaphor. If you lose a leg, you use a mechanical prosthetic to help you walk. The psychodynamic theory says that if you lose your internal ability to regulate anxiety, you use a chemical prosthetic to do it for you.
Yes, and this leads to Kantian's famous self-medication hypothesis. The hypothesis suggests that an addict's drug of choice is rarely an accident. Patients experiment with various substances until they find the specific pharmacological profile that perfectly treats their specific psychological deficit.
The drug fits the wound perfectly.
It's exactly. Consider a patient suffering from profound, crushing anhedonia and feelings of worthlessness stemming from childhood neglect. They feel internally dead. When they discover a powerful central nervous system stimulant like cocaine or methamphetamine, it acts as a magical cure. It provides an artificial surge of energy, grandiosity, and life.
They don't use meth to get high, they use it to feel normal.
Right.
And what about someone at the other end of the spectrum? Someone who is overwhelmed by intense, threatening trauma memories or seething with unexpressed narcissistic rage.
They will likely gravitate toward the obliterating, numbing effects of high-dose alcohol or opioids like heroin. The opioid acts as a chemical fortress, muting the rage and wrapping the fragmented self in a warm, artificial blanket of safety. The drug is a highly specific, albeit ultimately destructive, coping mechanism.
So, if a patient is using heroin as a prosthetic to manage horrific childhood abuse, the psychodynamic therapist's job is to gently remove the prosthetic, explore the abuse, and help the patient build the internal strength to heal the underlying wound. Why wouldn't a clinician start with this immediately? I mean, why waste time with the fishbowl and the CBT if the real problem is a fractured soul?
If we connect this to the bigger picture, attempting deep psychodynamic trauma work while a patient is actively addicted is clinically disastrous. The sources are incredibly explicit on this point, laying down a fundamental clinical rule.
It's like trying to perform delicate open-heart surgery on a patient who is actively running a marathon.
That is the perfect analogy. If a therapist dives into unstructured exploration of early childhood sexual abuse while the patient is still highly unstable or actively using, they are ripping off the emotional bandages covering a massive psychological wound.
And the patient can't handle it.
The patient is flooded with immense pain, terror, and anxiety, but they do not yet possess the sober coping skills to manage it.
So what is the inevitable outcome?
They will immediately flee the therapy and turn back to the only prosthetic they know that works, the drug. The therapist, in their zeal to heal the trauma, inadvertently triggers a massive, potentially fatal relapse.
The physiological vital signs must be stabilized before you can open the chest cavity.
Establishing behavioral control must precede deep psychodynamic exploration. The clinician builds the scaffolding first. They use the blunt tools detox, 12-step programs, CBT, contingency management, or medication like buprenorphine to stop the marathon.
Build the safety net.
Yes. Only when the patient has achieved a solid foundation of abstinence and has built up some rudimentary cognitive coping skills can the deep transformative psychodynamic work safely begin.
The healing requires immense patience, and the literature notes that this deep healing cannot occur solely within the isolation of the therapist's office. Addiction thrives in secrecy. It breeds a toxic false bravado where the addict claims they don't need anyone else. So therapeutic modalities must expand to involve the patient's wider ecosystem.
This is where modalities like network therapy and family therapy become essential. Network therapy brings the patient's peer and support group into the clinical setting. It dismantles the secrecy by having the patient recount the realities of their week in front of the very people they are trying to hide from.
And family therapy addresses the rot in the foundation. Because if a patient spends 6 months in rehab getting clean, uncovering their trauma, and building CBT skills, but they are discharged back into a deeply toxic, dysfunctional family system, the structural integrity of their recovery is going to collapse. Family therapy works to resolve that spurious self-sufficiency and rebuild authentic, reliable attachments.
It really is a team effort.
We have charted a massive expanse of clinical territory today. We began by staring at the neurobiology of craving in an fMRI scanner, realizing that addiction hijacks the brain's fundamental need for reunion and survival. We stepped into the clinician's shoes, utilizing tools like the cage aid and exhaustive collateral investigation to cut through the brilliant denial of addicted professionals. We weighed the agonizing balance of the least restrictive environment against the reality of a patient bent on self-destruction.
We examine the absolute necessity of cultural humility, understanding that a patient's intersecting identities and historical traumas hold the key to accurate diagnosis. We explored the subtle power of motivational interviewing, replacing the destructive theater of confrontation with the quiet strength of evocation.
And finally, we unpacked the heavy machinery of recovery, rewriting the behavioral software with CBT, jump-starting the dopamine system with contingency management and exercise, and only when the foundation is secure, doing the delicate, profound work of healing the fractured self through psychodynamics.
It is a multidisciplinary war against a disease that fundamentally corrupts human behavior.
As we conclude this deep dive, I want to leave you, the listener, with a final provocative thought. We live in an era of rapid technological acceleration. Right now, there is a massive surge in digital therapeutic smartphone applications driven by complex algorithms that can deliver CBT modules, track behavioral cues, and even offer variable rewards, all from a screen in your pocket. They are incredibly efficient and highly scalable.
Which is undeniably necessary given the severe global shortage of trained addiction counselors.
True, but here's the question I want you to carry with you. As artificial intelligence and machine learning become exponentially more sophisticated, could an algorithm ever truly possess cultural humility? Could a machine ever perform the delicate dance of motivational interviewing, recognizing the subtle shifts in a patient's deepest shame and ambivalence? Or is the messy, profound, inherently flawed shared human connection, the raw empathy of one person sitting across from another in a quiet room, the one irreducible active ingredient in healing addiction that a machine will never, ever be able to replicate?
It's a profound question.
Thank you for joining us on this deep dive into the labyrinth of addiction counseling. We'll see you next time.